So, finally, our last module in mental health, module 23 on cognition, that includes Alzheimer's disease, delirium, and schizophrenia. And then there's some pharmacology on antipsychotics. So I'm going to split this to two recordings. I'm going to do the concept of cognition, Alzheimer and delirium, and then I'll do a second recording on the schizophrenia and the antipsychotic drugs. Okay, gotta get this thing to go. So, cognition, to obtain a level of survival and adaptation, function effectively as a social being, engage in meaningful and purposeful activity. It's a complex set of mental processes by which an individual acquires, stores, retrieves, and uses information or is able to think. Perception is interpretation of stimuli, internal and external. It occurs in the brain. Attention is alert, aware, selectively prioritizing. Memory is retaining, storing, and retrieving information. Communication, memory impacts communication and speech. Social cognition is processing accurately. Motor is cognitive and motor they share neuron paths. Praxis is carrying out motor activities smoothly. Executive is needed for planning and execution of complex tasks. Intellectual is mental capacity to learn, reason, and problem solve. Adaptive is conceptual, social, and practical skills needed to function in everyday life. To obtain a level of survival and adaptation, to function effectively as a social being, to engage in meaningful, full, and purposeful activities. So, the manifestations of alterations in cognitive function. The general manifestations start on page 1708. Go on quite a bit. We're going to go over, I have it broken up here. I also want you to look at table 23.1 on page 1708, indicators of disordered thinking. These loose associations, tangentiality, incoherence, word salad, when it's illogical, pressure, distracted speech, poverty of speech. Not that I'm going to specifically ask you these terms, but is terminology that you will be using, understanding. This will help you if you read these to help you what you're doing for assessments and how you're documenting, especially pressured speech and poverty of speech, loose association. So when you're documenting, you're talking about their thinking process. So this is a good table to look at. So alterations or disturbances in perception, which is on 1708. Just made a little chart here, interpretation of stimuli or inputs that take place in the brain. That all that input, internal and external, brings us to understand and orient to person, place, time, and situation. Internal stimuli are our proprioceptive sensations that contribute to motor, functional, and spatial awareness. You should remember that word from health assessment. Alterations or disturbances in our perception. That's where we talked about the orientation. So confusion and difficulty thinking clearly, disoriented, times 1, times 2, times 3, times 4 of the four parts, your person, place, time, and situation. So confusion is increased difficulty thinking clearly, making judgments, focusing attention. Disorientation, the person cannot correctly identify one or more of the person, place, time, or situation. Psychosis, altered perception of reality, abnormal mental state that alters thought processes and content in a way that alters the person's perception of reality. Delusions are rigid, false beliefs. They're rigid. Persecution, reference, or grandeur. That's significant with and hallucinations with your schizophrenia. Hallucinations are sensory experiences that do not represent reality. They can be auditory or visual or tactile. Alterations in attention, which is bottom of page 1708 into 1709. Attention difficulties characteristic of many cognitive disorders may occur as a distinct disorder, significantly altered by experience of illness or stress. They can't decipher, can't figure out what to let in, what not to let in, so every sensory is being stimulated. An individual may lack the ability to preview and inhibit an inappropriate, unsafe response or action. Alterations in memory, it's quite a bit when we get into here in Alzheimer's or dementia, may be the initial manifestation of cognitive disorder. It can be temporary or chronic. Temporary would be your delirium. May be related to underlying illness or trauma that is very significant. When you're doing assessments, you do not assume that it is a dementia or that it's because of old age. You have to do a full assessment of every possible contributing factor. Can affect short-term and or long-term. Some terms, your confabulation is unconscious attempt to compensate for memory gaps by filling them in with fabricated events. You've probably witnessed this, but didn't even know that there was a term for it. Of course, agnosia, the inability to recognize objects through the use of one or more senses. You did that in health assessment, like putting a coin in their hand or something like that and identifying it. And amnesia is a general term that's used to refer to loss of recent or remote memory. Alterations in communication and social cognition on page 1709, common in many neurocognitive disorders. And remember, schizophrenia, which is the last exemplar in cognition, is a brain disorder. So it is a neurocognitive disorder. That's why they put it in this section. So alterations in communication, social cognition, essential component of cognitive function is ability to receive, interpret, and express communication. So you'll see this alterations in a stroke patient, but also in dementias and schizophrenia. Social cognition is ability to process and apply social information accurately and effectively, essential for adaptive functioning. Aphasia is inability to use or understand language. It can be expressive, receptive, or mixed. Anomia is a type of aphasia in which a person can't recall names of everyday objects. Alogia is lack of speech or impoverished speech. Our frontal lobe, right brain dysfunction affects our spatial awareness. Impaired visual processing can disrupt ability to read and respond to nonverbal cues. There's a risk for health problems, social isolation, victimization, and depression and anxiety. Actually, on your study guide, you will note I wrote some things, some specific parts of your terminology and functions of the brain that are scattered throughout this module, and I just gave you specific to understand and remember. Alterations in motor coordination, which is on 1709 into 1710. These terms, dyspraxia is difficulty with acquisition of motor learning and coordination through a process of growth and development. Apraxia, alteration in speech resulting from impaired motor function. Ataxia is balance and coordination problems, and some of these should be familiar from health assessment. Involuntary movements, tics, are semi-involuntary movements that are sudden and repetitive, non-rhythmic. It can be also in their voice muscles. Patient may be able to suppress them, but with discomfort or anxiety. Tremors are unintentional rhythmic movements. So your tics are not rhythmic, your tremors are rhythmic. Or carphologia is lint-picking behavior, often seen in dementia. Dyskinesia, we'll make that. Akinesia is diminished movement as a result of difficulty initiating movement. Some more terms you will see there on 1710. Rigidity is resistance to movement. Dystonia is acute muscle contractions. Alterations in executive function is, it's also in 1710. Mental skills involved in planning and executing complex tasks, significantly affected by structural and physiological abnormalities impacting the frontal cortex, or executive, emotional, judgment, memory, planning, organizing, concrete thinking, personality changes, and avolition or decreased motivation or an inability to initiate goal-directed activity. Risk factors for altered cognitive function. As you can see, I have skipped through, should have been covered in pediatrics. I am not going there. Selected alterations in cognition for intellectual disabilities, Fragile X, fetal alcohol syndrome. I'm going to your risk factors, your delirium and dementia we will be coming back to. Well, let me go ahead and talk about these a little, even though I don't have it on the slide. So your delirium is usually an acute change in mental status characterized by confusion, inability to focus, shift, or sustain attention, disorientation, sleep-wake cycle disturbance, disorganized thinking, perceptual abnormalities, mood changes, and psychomotor retardation with agitation. Delirium is in our exemplar B, and we will talk about that some more. Dementia is in your exemplar A, and we will mostly focus on Alzheimer because that's 80% of dementias are Alzheimer, but not all dementia is Alzheimer. So dementia demonstrated limited impairment. Loss of one or more cortical functions or cognitive attributes as a result of degeneration of the neurological system of the brain. Alzheimer's most common form and has a vascular or neurocognitive dementia. Then you see your schizophrenia is down on the bottom, page 1714, which we will get into more, represents one type of psychotic disorder, and it's an exemplar B. 1% of warlike population meets the criteria for schizophrenia. Okay, so back to my current slide. Risk factors. Are your age, sex, exposures, familial, genetic. We will get into some of that as we cover into the exemplars. Modifiable is your lifestyle and possible other health conditions. blood pressure is a big one. Well, on this page, on the bottom of 1716, concepts related to cognition, some few points in here. Cerebral perfusion is necessary for normal cognitive function. So anything that impairs our oxygen or blood flow to our brain will impair our cerebral perfusion. If we don't have enough blood flow to our brain, it results in inflammation. Metabolic changes, whether it's your glucose or anything else in your electrolytes, your metabolism, can impair our cognition. Subtle variations can lead to a delirium in older adults. Then chronic cerebral hypoperfusion, less than we need, from decreased cardiac output and vascular changes have been linked to degenerative changes, neurological changes, and Alzheimer's disease. So things like your COPD or your smoker that's not having enough oxygen, your brittle, your diabetic with the up and down, your hypertensive patient, your renal patient, kidney failure patient where their electrolytes are off balance, person that has major GI issues, or have they had a stroke that has impaired that? Are they hypoglycemic? Are they in DKA? Or do they have an infection, some sort of sepsis going on? Is it the pain that has caused a change? Multiple things, trauma, all these have to be ruled out and looked at because it can be a combination. Even if they have a dementia documented, it may not be an exacerbation of that. It may be other things that are contributing. A biggie with your confusion. Oh, I'll get that when we get to delirium. Sorry. You can have permanent brain injury, and it said hypertension, I think I mentioned. Okay. Sorry, I'm sitting outside, and sometimes it's hard to see the screen, and I can't get my mouse to go where I want my mouse to go. Okay. So, nursing assessment. Your nursing assessment is very key. You definitely want to look at your health promotion section on 1718, and I think I made notations of that in on your study guide. Prevention. I want to mention prevention here. Okay, there is primary, secondary, and tertiary. Primary prevention is when you're doing teaching and talking about foods and exercise and immunizations, things to prevent the problem from ever occurring. Once you start screening, you are looking for something that exists, so those become a secondary prevention. If you screen, that word is in it, it is a secondary because you're looking for something that exists and you're trying to decrease that risk, slow it down, prevent further complications. Tertiary prevention is when the problem exists, there's already issues with it, like you're putting them on dialysis, you're giving them more medications, the disease exists, and you're managing to try to limit the impact. Okay, just wanted to add that in. Nursing assessment. Any changes in cognition require immediate attention. It's never an assumption. That's in your safety alert there on page 1718. If changes in cognition, assess your vital signs, O2 sat, changing gas exchange, look for oxygen deprivation, fluid and electrolyte imbalance, look at your nutrition, your vitamins, your intake, look at your brain. They may do imaging, looking for a stroke, CVA. Yeah. Oh, God. Got to get this to move. Observation and interview. Also on page 1718, observe appearance, dress, behavior. This was covered also in health assessment. What do you think contributed? When did the change begin? What's the frequency of the change? This is things for your best source of information is from your patient. Focus on the patient perception of the problem. You want to look at their past medical history, social history, childhood exposures, developmental history, family history, environmental factors. Looking here, it has a group of good questions you can ask there in 1719. Tools to assess cognition and mental status. These are on table 23.6 on page 1720. These are the three I want you to focus in on. Your confusion assessment cam. It takes 5 minutes to assess for delirium. Mini mental, 30 questions examining memory, language, attention, ability to engage in tasks. Again, these are in table 23.6. And your patient health questionnaire, which 11-item screening for depression. Those are the three to focus on, not the rest of that. Okay, so here's a little quick mental status examination, the questions you will ask. Sometimes a family member will have to answer some of these, like what you see here and what they tell you. So anyway, let's see. Your physical exam. Vital signs and pain level. Pain is important. Assessment of neurological signs. Hearing, vision, touch, taste, smell. Hearing and vision can impact a person's interaction, their thinking. Maybe it has to do with their memory or cognition. So always check the hearing and vision before you assume further. Assessment of physical development, height, weight, fat distribution, assessment of motor function. This is on page 1719, included there. If you look at it, you know you're looking at, so their vital signs and pain level, you're looking at the O2 saturation, you're looking at cardiac perfusion, peripheral perfusion, their pulses, their vascular flow, their skin integrity, everything that's telling you about their perfusion and their whole motor function, strength, coordination. Okay. Diagnostics. Assess underlying causes for cognitive changes. I said that. Toxicology. You have a section on page 1720. Looking for alcohol or substance abuse regardless of their age. Therapeutic drug levels for certain things that can really throw them off, like some of your anti-epileptic, your seizure drugs, some of your antibiotic drugs, aminophylline. Looking at liver function, CBC, you're looking for infection, different kind of anemias, whether it's an iron deficiency or B12 or a folate deficiency. Your thyroid function, I call it your little motor in there. If it's underactive, your motor is revved down, and they will have motor issues, memory issues, strength issues. Hyperthyroid, they will come across, if their thyroid is too active, as if they're hyper, but it's really their thyroid. Thiamine, B1, biggie in your alcoholics. Looking at for UA, urinalysis tells us lots of things. Filling out a glucose, big in your older population, and UTIs being a major contributor to acute onset of confusion, which is your definition for delirium. HIV, sexually transmitted infections. Genetic testing, looking at cerebrospinal fluid. Lifespan considerations. Brain matures approximately age 24, males it may be up to age 30. Older adults, this is important. Older adults are on page 1728, cognition in older adults. I do have that specific section on your study guide, moderate brain shrinkage and decreased blood flow, more difficult with word retrieval and episodic memory. Impact on overall cognition function should be minimal. Moderate to severe cognition decline is not a normal part of aging. Moderate to severe. Dementia. Progressive loss of cognitive function is not sudden, it is progressive. It's now classified as mild and major neurocognitive disorders. Alzheimer's said is the most common one, about 80%. Vascular or neurocognitive dementia results from multiple small strokes or infarcts to the brain, can be caused by or exacerbated by other conditions. I mentioned that metabolic poisoning, infection, nutrition, medications, hypoxia. It can be a combination of things there. So good assessment, history taking is important. Delirium versus dementia. It's very important to be able to distinguish between these two. Delirium is your rapid onset versus dementia is your slow and progressive. So your black side is your delirium, the red side is your dementia. So be able to go between these two and understand the difference in them if you're given scenarios and questions. Here, delirium recovery is possible, depends on what's causing it, how extreme it is, but it's usually, and it's not always rapid. Here, delirium, rapid mood swings versus dementia with depression and apathy. Delusions and hallucinations are possible with delirium and often visual. Dementia may or may not occur. Usually it's in the later stages. Okay, so now we're going to go into Alzheimer's disease, which is exemplar 23A. Pathophysiology. Exact etiology is unknown. There's early onset, which is familial, inherited before age 65. That's early onset. Late onset or sporadic Alzheimer's disease is after age 65, and it is the most common. And you will see questions on that, so understand that. Progression. Progressive degenerative changes. This is Alzheimer's or even just dementia related to neuronal death. Now, with Alzheimer's begins with neurons in the limbic system, including hippocampus. Again, I put notes specific to this, like in your whole brain function section on your study guide. It spreads up and out toward cerebral surface. They have amyloid plaques, which are insoluble deposits that damage the surrounding neurons, killing them and provoking an inflammatory response that may result in further brain damage, and your neurofibrillary tangles are abnormal proteins that join and twist. You do need to understand the different stages of your Alzheimer's. Here on this slide that I found that I'm sharing, it has mild cognitive impairment, mild Alzheimer's, mild, moderate Alzheimer's, and severe Alzheimer's. And your text, page 1733, has your stages, stage 1, stage 2, stage 3, and stage 4. Sorry, got carried away, there is no stage 4. Okay, so the Alzheimer is about 80% of dementia cases in individuals age 65 and older. Currently the 6th leading cause of death in the United States. Usually manifest after age 65. There is an early onset that's familial that can be before, but most are after age 65. Most survive between 4 to 8 years after diagnosis. Risk factors. Trying to find what page page that's on, page 1731, advancing age, family history, women 3 times greater than men, Hispanic and African American, so risk, cardiovascular disease, hypertension, dyslipidemia, obesity, diabetes. That's cigarette smoking, sedentary lifestyle. And you see where you get back to preventive measures of healthy lifestyle is so important. So the risk of developing Alzheimer's doubles every 5 years after the age of 65. Broke up risk factors, there's modifiable, non-modifiable, and some other factors. Lower level of formal education, history of brain injury, brain trauma, TBIs, depression, and disordered sleep. So this is why everything is so important. Okay, prevention. Evidence-based teaching for general public prevention. Excuse me. Okay, reducing risk of cardiovascular disease, healthy lifestyle, healthy diet, controlling blood pressure, preventing hypertension if possible, moderate consumption of alcohol. No alcohol is better. There is some things that talk about, I think it's here in 1731, moderate alcohol consumption may be protective, however, evidence is insufficient. So if you don't already drink, do not consume alcohol thinking it's preventive. Engaging activities that exercise cognitive function, doing puzzles, reading books, even staying socially active, interacting with people, taking college courses, different things like that. Stress management techniques, decreasing your stress level. Hard to think of that when you're in nursing school. Clinical manifestations. This is on page 1732 through 1732. Your diurnal changes, your up-down time, changes in mood and personality, decreased initiative, odd behavior, signs of depression, and progresses through 3 stages. Now I wrote it on your study guide. So your stages here, you need to understand the stage, the manifestations of that stage, and what therapies are appropriate for that stage. So your stage 1 has reduced concentration and memory lapses noticeable by others. Problems functioning in work or social settings. So your therapies are patient and caregiver education and training. With Alzheimer's, the patient and caregiver, your plan for advanced stages, it is in stage 1 upon diagnosis that you talk to the patient and family and start planning for what they're going to do when they hit the later stages. It gives them time to think about it, to plan, and be involved in this and make informed decisions. Promoting safety. Schedules. You want routines, daily routines. Keep everything specific and routine. To-do lists, calendars are excellent tools. When they get to stage 2, I'm missing my page for stage 2. Stage 2 on page 1733, inability to carry out ADLs such as preparing meals for oneself and choosing appropriate clothing. So behavioral interventions, cueing devices, assisting with their ADLs, having things to remind them what they need to do, continue to establish routines. This is where pharmacological things can be started. Consult dietitian and nutritionists because that's extremely important. respite care for family members and other caregivers. When you get to stage 3, it's a gradual loss of remote memory, gradual loss of ability to walk, sit, hold their head up. They need round-the-clock care, frequent repositioning, liquid nutrition, planning for end of life, continued pharmacologicals, possibly need some atypical antipsychotics because they can have hallucinations at this point, possibly. Nursing implementation is on page 1736, 1737. You'll see on your study guide in all your exemplars, I said to look over your whole nursing process. So you need to understand your assessment. And Alzheimer's really good on 1735. Well, in all cognitive impairment, dementia, when looking at dementia, assessing for drugs and alcohol, eyes and ears, so vision and hearing, metabolic and endocrine, emotional, neurological, trauma, tumors, infection, arteriovascular disease. I forgot about that when I was talking earlier about your assessment, but that's a great little tool for you to remember everything you're checking and never assuming. So, safety alert on page 1737, the use of physical and pharmacological restraints in individuals with AD and dementia significantly increases the risk of injury and death and is never considered therapeutic. Never. You're going to have different kind of therapies, occupational therapy, physical therapy for their strength and movement, occupational therapy to teach them those cueing and tools to continue as much of their activity of daily living that they can until they reach a stage where they can no longer do it. That's why they are a significant tool. Okay, so delirium, almost done with this part of the lecture. It's 23B, and I said it is the acute onset, abrupt, usually transient change, comes and goes in mental status and consciousness usually. Disorganized thinking, disorientation, perceptual disturbance, restless, agitation, liability, distinct from confusion. I will give you an example. A patient I had that I actually knew outside of work for several years. He was in his 70s. He came in and had a AAA abdominal aortic aneurysm repair, so I had him in the cardiovascular intensive care unit. And between the anesthesia, the lights on, the pain, the medications, everything, I was working night shift, and somewhere in the middle of the night, this totally with it, no cognitive impairment, suddenly starts screaming out. He's looking in his pillowcase, literally reaching in his pillowcase, looking for his wife. Got very combative when we tried to reorient him, calm him down, and he one time it was so interesting. It wasn't confusion because he looked at me and he said, "Patty, you and I have been friends for years. But if you don't let me get," I forget his wife's name, "her out of this pillow," and he knew it was a pillow, "I am going to punch you, and I don't want to do that." So there's your distinction. It was not confusion. Luckily, he was out of it, got out of ICU, got upstairs, was sleeping better, anesthesia out of his system. He sent a message for me, come up and see him, and when I did, he said, "My wife tells me I misbehaved, and I apologize, I have no memory." Experienced the rates of 6 times greater in hospitalized older adults. Now, delirium can happen in children. I want you to keep that in mind too. So read your section 1742, delirium in children. They're very young and very old. It's not very likely to occur in adolescence, although it can. So very young, very old. And the delirium in children, febrile illnesses are the greatest percent of it, and you want to encourage the family to stay with them. So you have your nursing process promote resolution of whatever condition is causing it, often manifestation of dehydration, respiratory infection, UTI, urinary retention, adverse drug events, and in children, fevers. Rule out change in cognition, due to vision or hearing. I mentioned that before. That is very key also. Confusion assessment tool, your CAM, to distinguish between delirium, depression, and dementia. Delirium is fluctuating state. It can be recurrent. It can come and go, so you have to continue to do the assessments. Risk for injury with acute confusion. Nursing implementations, maintain appropriate level of noise and lighting, dim the lights, take them away from stimuli. Use behavior interventions to address wandering, promote consistency in caregiver through assignments, environment that promotes normal wake-sleep cycles. That is so important. Keep familiar items in the patient's environment. This is delirium. Back on your Alzheimer's, which is your dementia, you want to keep some familiar things around them, but you want to limit how much is there. You don't want it to be distracting in dementia patient, but you need familiarity. Where delirium, it's an acute state, so you want some things familiar around them. Use calendars, clocks, signs to assist with orientation, and encourage family visitation. I am going to stop the recording here. We'll pick up on the next recording with your schizophrenia and your pharmacology.